Good morning. Good morning. Thanks for coming to the GI section. Without any bias, I'll say this is obviously going to be the most interesting one. So thank you for not going anywhere else. We have some interesting talks today. I think they're all a little bit different perspectives, and you know, I think a little surgery action, and then some medical oncology, and then some kind of public health perspective too. So I think this will be really interesting couple hours with us. If we have time at the end of each talk, we'll do some Q&A. If we don't have time, then maybe save your questions for afterwards and catch the speakers as they finish and walk out. And without further ado, since we're already taking time, I'd like to introduce quickly our first speaker. So our first speaker is Dr. Justin Barr. Dr. Justin Barr is a transplant and hepatobiliary surgeon at Ochsner. He joined us within the last year and has already made his presence very known and has been a fantastic addition to our team. Dr. Barr did his medical school at University of Virginia, residency at Duke University, and his fellowship in transplant at University of Toronto. Lest you think that CV was not enough, he got a PhD in history from Yale University. And, I thought I was cool because I wrote a rhyming ABC children's book, but Dr. Barr actually wrote a real book, published book called Of Life and Limb Surgical Repair of Arteries in War and Peace, 1880 to 1960. So, if you want some casual reading for tomorrow when the conference is over, I highly suggest you check it out. It's cheaper on Kindle than on the hardback. All right. So Dr. Barr, want to come up and give us a talk on A Chance to Cut is a Chance to Cure Colorectal Liver Metastases.
Well, good morning. For a talk on nothing to do with history or arterial repair, I'm here to talk a little bit about managing colorectal liver mets. Thank you, Dr. Mizrahi, for the introduction and for the opportunity to speak here. Thank you guys very much for coming. Does this button work or no? No, okay. None of these buttons work. Good. Okay. My financial disclosures are here and are not relevant to my talk today. My intellectual disclosures are managing colorectal liver mets is obviously a multidisciplinary endeavor. I'm not smart enough to be a medical oncologist like Dr. Mizrahi. I don't like poop enough to do colorectal surgery, and I don't like getting nuked, so I'm not an interventional radiologist. But obviously, all of these specialties have a tremendous amount to contribute to these patients. I'll just touch on some of what they have to offer, but I'm not an authority. I'm not the oldest person in the room today. There are other people who have more clinical experience, but I have a different training pedigree, and I think I can offer some perspectives that are interesting and valuable here today. It's a huge topic. I'm not able to cover everything, and I did steal a few slides from my colleagues, Dr. Yu and Dr. Wei. We'll briefly talk about the scope of the problem before examining how surgery can help these patients and some of the specific strategies that we have in the operating room. We'll explore the combination of chemotherapy and transplant before discussing what were previously considered unresectable lesions that we can now manage through pumps and transplant in some cases before drawing a few conclusions. Just because you have colorectal disease that is metastasized outside of the liver does not necessarily preclude you from resection. These cases are more nuanced. You can sometimes get cytoreductive surgery, HIPEC, radiation to lung lesions. They are beyond the scope of my talk here this morning. The emphasis that I want to make is that you can still, in some circumstances, reach resection, but I will not be talking about them today. So as everyone here knows, colorectal cancer is obviously a huge problem. There's around 150,000 new cases each year, around 50,000 deaths. It's the third most commonly diagnosed cancer in the United States. This slide may be small. The circle says that it is the second leading cause of cancer deaths in the U.S. But importantly, this circle here says that there are over 1 million colon and rectal cancer survivors living in the U.S., and our goal is to increase that number through some of the therapies that I'll be discussing here today. Colorectal cancer has a tendency to metastasize. About 20 to 25% are metastatic at diagnosis, and about 50% will eventually develop metastases. And unfortunately, this number has been increasing since 2016. Over half of all new cases either have local, which is to say nodal involvement, or distant metastatic disease. And part of this increase is due to the influx of younger patients. You may have seen stories about this in the lay news media, New York Times, CNN, etc. In the last 10 years or so, there's been a 15% increase in younger patients who are developing colorectal liver cancer. And unfortunately, they're more likely to present at an advanced stage. So if you look at this graph in the bottom corner here of the older people over 65, their number of diagnosis has actually been decreasing, and the number of metastatic disease is actually a relatively small percentage of their cases. The middle-aged folks from 50 to 64 has been relatively stable, but if you look at the younger people, which I barely am eligible to include, as increasing in the number of distant metastases is a higher proportion of those cases. Now, as a surgeon, this is helpful because it's easier to do a big operation on a 25-year-old than on an 85-year-old. But obviously, from a society standpoint, it is really unfortunate and terrible that younger people are being afflicted by this disease, and we're currently exploring why that is and how we can better manage them. As discussed, about 50% of cases will develop colorectal liver metastases. About half of these are synchronous or present at the same time as the presentation of the colon or the rectal cancer, and about half will present sometime later. I titled my talk, "A Chance to Cut is a Chance to Cure," because we can actually cure a percentage of these patients with isolated colorectal liver metastases, about 20 to 25%. And there are very few other GI cancers that when they're metastatic actually have an option for surgery, even for prolonged survival, much less for actually cure of the disease. But this is not always the case. Putting on my historian hat, as late as the 1990s, surgical intervention for metastatic colorectal cancer was considered not an effective therapy. It was thought you were providing a local treatment for a systemic disease. But studies that came out in the late 90s and the early 2000s demonstrated that it was actually tremendously efficacious. This is about 2,500 patients that came out of MD Anderson and Mayo Clinic in Minnesota that showed if you have metastatic colorectal cancer and you do no treatment, unsurprisingly, those patients do very poorly. If you just offer them chemotherapy, you have about a 20% 5-year survival. If you add surgery to this mix, you have a 60% overall survival in 5 years, which is obviously a huge improvement. And again, at 10 years, 25% of patients are still alive. So you consider 25% of patients with a metastatic GI cancer we can actually cure, which is a remarkable achievement. These are data from Sloan Kettering showing effectively the same thing, except survival has been improving recently with more modern interventions. If you don't believe American data, this came from England, which again shows a big difference in the blue line of patients who got surgery versus the red line of patients who only received chemotherapy. And so unsurprisingly, surgery became a more standard intervention as the number of resections increased, particularly in the last 10 to 15 years for metastatic colorectal cancer. But there are some problems in managing colorectal liver metastasis with surgery. One is that only about 10 to 30% of patients with colorectal liver mets are actually eligible to undergo resection, and that's for a few reasons. One is patient's overall condition. If you're 95 years old on dialysis with an artificial heart, I really can't take you to the operating room to remove half of your liver. The other option is if there's extensive disease outside the liver. So I mentioned some cases can get resection, but if you have widespread metastases, then removing the few lesions in the liver does not seem to help those patients. And then third, although this one is questionable, is extensive disease inside the liver. We are increasingly managing that surgically. But for the most part, these three elements are non-modifiable. I can't change if you're 95 years old or whether you present with tumors outside the liver. The modifiable barrier to resection are those patients who are in fact resectable based on imaging or laboratory studies but are not reaching the operating room. And studies suggest that between 5 and 20%, only 5 to 20% of patients who are resectable are actually undergoing liver surgery for their colorectal liver mets. This is a survey data of all the medical oncologists at Michigan. It's a little bit old, coming out 10 years ago. They got a response rate of 50%, and it showed that 80% of medical oncologists thought that lesions outside the liver were an absolute contraindication. 60% thought more than 4 lesions were a contraindication. 40% thought that bilobar mets or mets greater than 5 centimeters were contraindications to surgery, none of which is true. And this is not the fault of the medical oncologists. I don't keep up with their literature. I don't expect them to keep up with ours. I think it does emphasize the importance of having these patients see surgeons and interact with surgeons. And so if you ask the question, who should actually see a surgeon if they have colorectal liver mets, I would argue every patient with colorectal liver disease from colorectal liver mets should see a surgeon either independently or ideally as part of a multidisciplinary tumor board. These are data essentially showing the same thing for randomized controlled trials, looking at a separate intervention that is not relevant. The important fact is that trials that did not have a medical oncologist as part of the recruitment board had a much lower percentage of patients reaching surgical intervention than those trials that did have a surgeon as part of their recruitment board. So these patients, if there's one take-home point, all colorectal liver met patients should see a surgeon. Let us tell them that, I'm sorry, no, you're not a candidate and not eligible. So who can get resected? It doesn't matter how big the lesions are. It doesn't matter how many lesions there are. It doesn't matter what your CEA is. It doesn't matter what your TNM stage is at diagnosis, whether you've had prior surgeries, prior liver resections for colorectal liver mets. None of these absolutely eliminate you from receiving surgery as long as we have enough liver left to allow you to survive after the operation. Now, certainly these factors influence your survival after the surgery. This is a table showing a variety of clinical risk scores that use the number, size of lesions, CEA level, in order to estimate how well you will do after surgery. Perhaps the best known is the Fong clinical risk score out of Sloan Kettering. They all have their strengths and weaknesses. They're all useful. This is a table that shows that if you have a lower score, which is to say fewer lesions or smaller lesions, you tend to do better than those patients who have more or larger lesions. But even those patients with more or larger lesions still do much better with surgery than not getting a resection at all. So what are some surgical principles? Obviously, you want to remove all of the cancer. Doing surgery and leaving cancer behind does not seem to help patients. In the very old days, they were doing anatomic resections, left and right hepatectomy. This was quickly demonstrated to be overkill. And so margins of 1 centimeter or more were recommended for much of the early 21st century. More recent data have suggested that you can get away with even smaller margins, or basically no tumor on ink, and even can have an R1 resection off the vascular structures inside of the liver with equivalent oncologic outcomes. Although some of the most recent data would suggest possibly going back to this 1 centimeter margin, one of the great challenges is trying to guess the margins ahead of time. So this is a trial that came out of Sloan Kettering, certainly very experienced surgeons. They would survey the surgeon and the fellow both before the operation started and after they removed the specimen, and ask the surgeon, what do you think you got as a margin? And they're only right 50% of the time, which is not terrific. And this is not just positive, negative. It's whether it was a close margin, a distant margin, or a positive margin. But the ones that we're most concerned about, of course, are the number that are moving into this blue box here, which they thought were going to be a negative margin and ended up being a positive one. It is a small minority of cases, but it is devastating to the patient who underwent significant risk of morbidity and mortality for minimal to no oncologic benefit. And if they thought they were getting a margin greater than 10 millimeters, then they were more likely to get a negative margin in these cases. This is a systemic review of about, they looked at 1,000 trials. They analyzed 6 of them, mostly colon, not rectal cancer. It did show that if you have a larger margin, you have less mortality. So margins of 1 to 10 millimeters had a 30% increased risk of mortality compared to margins greater than 10 millimeters. This is a study that is not even yet published. It's just been accepted for press in Annals of Surgery, again at a Sloan Kettering, showing an overall recurrence rate of around 61%, which is about average for the literature, and that patients with greater than 10 millimeter margin, which is this top line here, had a much better recurrence-free survival than patients with a smaller margin. They did not assess overall survival. Now, the question is it really the margin status that is determining this overall survival, recurrence-free survival, or is it actually indicative of tumor biology, and that more aggressive tumors tend to be more infiltrative? It's harder to guess the margins, and you're more likely to get a narrower margin, which then leads to poor outcomes. We don't know the answer, and honestly, we'll probably be debating 1 versus 10 millimeter margins for the next 10 years. I think that's sort of getting down into the weeds. The important point is you need a negative margin, and if you do have a negative margin, these patients do markedly better. Now, you can't pick up a surgical journal today without one of the articles talking about the benefits of minimally invasive liver surgery. This was historically laparoscopic surgery. This is a randomized controlled trial showing that patients who receive laparoscopic surgery for colorectal liver mets have equivalent oncologic outcomes and far better morbidity and mortality. Laparoscopic has a much steeper learning curve, and so most surgeons are transitioning to robotic surgery today, and it's been essentially accepted that it is a superior modality when it is technically possible. Now, I'm talking about surgery in isolation, but it certainly doesn't exist in isolation. It is really part of a multimodality therapy that includes things like chemotherapy and pump therapy that I'll talk about a little bit later. Right now, I want to focus on ablation, which can be part of the surgical arm. Ablation was invented for hepatocellular carcinoma. You take a probe and you physically put it into the lesion and then destroy the tumor cells with some form of energy. You can freeze them, you can nuke them, you can burn them, and it's been proven to be quite effective for small HCCs of less than 3 centimeters. But there's always been a question about whether it would also work or be similarly effective for colorectal liver metastases. And the answer until recently has been largely probably not. This is a meta-analysis from 2019 out of Europe that examined about 1,700 studies. 18 of them were ultimately analyzed, and they look specifically at radiofrequency ablation. Not a single study demonstrated superiority of ablation, and the majority demonstrated superiority of resection when possible, as opposed to ablating these tumors. And so from this study, at least, we consider surgical resection to be the gold standard in these cases. Now, there are some lesions that are particularly difficult to get to or would require a morbid operation, and so you wonder whether ablation would be a viable strategy. And fortunately, we have data from the Collision trial, which just came out last year. It was a multi-center randomized controlled trial with about 150 patients getting ablated, 150 being resected. All these patients had small tumors and a relatively low burden of disease. And this trial, at about 2.5 years, did demonstrate equivalent outcomes between ablation and surgery. We'll be looking for the 5 and then ultimately the 10-year outcome. And then next year in 2026, we're expecting data from the HELARC trial, which is looking specifically at tumors presenting synchronously, again, smaller than 3 centimeters. So some of the newest data would suggest that ablation is equally effective to resection, although long-term data remains to be seen. Now, if you do present synchronously, you have a colon or rectal cancer and you have a liver cancer, which do you take out first? You take them out both at the same time. There have been a gazillion studies looking at this. In the old days, they always took out the colon cancer first. Around 2006, Mentha proposed removing the liver lesion first. This was largely for rectal cancer patients who were undergoing radiation and couldn't receive upfront rectal surgery while they were healing from that radiation. This is a data, again, from Sloan Kettering. As you can see, the 3 curves here, one line is for liver first, one line is for colon first, and one line is for doing them at the same time. They're clearly overlapping. The data suggests that there's no significant oncologic difference in the vast majority of cases. You should tailor your approach to the surgeon's preferences, the center's preferences, and of course, ultimately, the patient's needs and their specific disease. Now, we saw this slide before and saying the major caveat for liver resection in these cases are we leaving enough liver left for patients to survive following surgery? And after at least chemotherapy, you need around 30% of your liver remaining. Well, what if you don't have 30% left? Are there any other options for you? And in fact, there are. There are a variety of strategies designed to help grow the remaining liver to give you a sufficient liver remnant. The first one was called portal venous embolization. It was introduced by the famous Japanese liver surgeon Maguchi in 1980. And very simply, you embolize the portal vein on the side with the tumors. This means this liver is not functioning as well, which makes this one function extra hard. It grows, and so you come back a few weeks later and resect this portion after this part has grown, allowing you to perform the surgery, remove the tumor while leaving enough liver for the patient to survive. This is a relatively low side effects and works somewhere between 60 and 80% of the time, depending on which study you want to read. This is a series of increasingly aggressive strategies that you can use to help grow that future liver remnant. The most aggressive is considered ALPS, where you not only ligate the portal vein here, but you actually go in surgically and transect the liver, removing the collateral circulation between the right and the left lobe, which forces this other side to grow much more rapidly and much larger. And then you go back usually 2 weeks later or so and remove the side with the tumor in them. ALPS procedure tends to be more successful at getting patients to the second stage of their operation, with about 95% reaching a second stage surgery. But at least according to this 2019 meta-analysis, it does have a significantly higher mortality rate, so bigger risk, bigger reward. There are no randomized controlled trials of which I know that compare these different strategies. It tends to be institutional preferences and the needs of the individual patient. Of course, one option is if you have unresectable liver disease, just to resect the whole liver and transplant it, and we'll discuss that towards the end of this presentation. Now, unfortunately, even if you do resect colorectal liver mets with a negative margin, around 75 to 80% of patients will recur, so their metastases come back, about half of whom come back in the liver alone, and those patients are eligible to go back to the operating room for a second resection, and about half will come back with disease outside the liver as well. And as these slides indicate, if you develop recurrence, of course, your prognosis is not as good. But instead of harping on the negative side, I again want to say that curing 25% of people with metastatic colorectal cancer is a remarkable achievement over the last 20 to 30 years of the medical field. We have much further to go. Obviously, we want to get the recurrence rate down to 0, but 25% is still impressive. And in some ways, this makes sense, right? If you have circulating tumor cells, it's a little bit weird if they locate just in 1 or 2 places in the liver. And so you might think that adding chemotherapy would help eliminate those tumor cells or any micrometastases and improve your disease-free survival and your overall survival. And you'd be half right, at least, because it does improve your disease-free survival. It doesn't seem to make as much of a difference in overall survival. So the ERTC trial looked at 365 patients with relatively low volume disease. They were randomized either to surgery or to surgery plus FOLFOX4, which was standard of care chemotherapy at the time. As you can see from this graph, it did show improved progression-free survival, at least until out about 10 years when the lines crossed. But if you looked at overall survival at 5 years, the outcomes were no different on whether you got chemotherapy or whether you just had surgery. If you did recur, then you were eligible to receive chemotherapy, so that arm did get chemo. This has been reinforced by a 2001 CAGLA 0606 study, which looked at 150 patients who had just surgery and 150 patients who had surgery plus chemotherapy. This trial was actually stopped early because the chemotherapy patients had such better progression-free survival, as you can see from this early graph here, although again the lines cross a disease-free survival again in around 10 years. And if you look at overall survival, the 2 lines are essentially identical, and the trial did not identify any difference in overall survival with those patients who received upfront systemic chemotherapy, which is really why I titled my talk, A Chance to Cut is a Chance to Cure. I was able to find 5 randomized controlled trials that examined whether chemotherapy extended overall survival. None of the ones that I identified showed that it did. Now, the critics to that will say that none of these trials are actually powered to look at overall survival, and that's 100% true. They're all examining or designed to examine progression-free and disease-free trial. And there's certainly patients who benefit tremendously from immunotherapy, such as MSI high tumors that we know should get chemotherapy, and immunotherapy was not included in these trial designs. But still, if you look at these survival curves, this one, if you stand next to it, you can fit your head between the people who got surgery and the people who just got chemo, and these lines don't seem to cross. Despite these data, almost all centers, including ours at Ochsner, does use chemotherapy in metastatic colorectal liver cancer. But I think if you have a patient who is unable to receive chemo, whether it's due to social reasons, economic reasons, or unable to tolerate the side effects, that should absolutely not preclude them from getting surgery, because it does seem that surgery is the main driver of survival length improvement in these cases. Well, what if they truly are not resectable? There's a couple different strategies you can use, including pumps and transplant. Right? There's no way to resect the lesions here, leaving you enough liver. Pump therapy is predicated on tumor biology, and that tumor cells are primarily supplied by the hepatic arteries, where the liver parenchyma has both a vein and artery supply. And there are chemotherapies that are digested or metabolized almost exclusively by the liver, specifically FUDR. And so you give the chemotherapy specifically through the pump. It only gets into the liver clears the disease. So you can give doses that are up to 400 times what patients would systemically tolerate, which has an incredible effect on the tumor cells. This initially came out of Sloan Kettering. This is some of their early data showing that there was an improved survival benefit in otherwise unresectable colorectal liver metastases. Their data tends to be a little bit old and comparing older regimens. This is a more recent study out of Pittsburgh from 2017 that again showed about twice your overall survival in patients who are undergoing pump chemotherapy plus systemic as opposed to systemic therapy alone. I'm running out of time. Adjuvant therapy is another use for the pumps that we can discuss a little bit later. One of the main critiques of pump therapy is that it worked really well on the Upper East Side of New York City, but other programs that tried to replicate those results had difficulty achieving similar outcomes. That has changed recently. This is a paper by one of my junior residents, Annie Liu at Duke, showing how Duke was able to set up a program while I was there that leads to great outcomes with reasonable complication rates. This is a table showing the number of centers using hepatic artery infusion pumps. So for essentially all of the 80s and 90s, it was just Sloan Kettering. You had centers try and then give up, try and give up. But starting around 2015 or so, you see a significant increase in centers that are utilizing this technology, including ours at Ochsner. And as a further effort to rebut this idea that the pumps only seem to work on the Upper East Side, Mike Litsky, who in full disclosure is my chief resident at Duke, has put together this actively accruing phase 3 randomized controlled trial comparing patients getting pump therapy plus chemo as opposed to just chemo, and hopefully we'll have some preliminary results in 4 or 5 years or so. Now, just last week was the American Hepatobiliary Association meeting, so these slides are hot off the press. I apologize for the quality because I was in the back row taking pictures of them with my cell phone. But instead of just using cytotoxic chemotherapy, there's a study that is presenting some of their preliminary results where after the standard 2 weeks of FUDR, they're actually using an IL-12 concoction with the idea that the chemotherapy is sort of activating the tumor and exposing it to the immune system, and then you can make the immune system work even harder in fighting those cancer cells during your otherwise 2 week of break period. This is the standard slide showing that your patient population is roughly the same. Note that there's only 9 patients in the experimental arm, so these data are incredibly preliminary. This shows that there's no increased risk of side effects using this IL-12 concoction. And this is a Kaplan-Meier graph that is exciting, but it's also statistically irrelevant. We have 9 patients. It's only been 2.5 years. But it nonetheless is promising, and I think heralds the excitement that we have in this field as surgeons and scientists continue to work together to bring forward new treatments in managing this disease process. Of course, if you have unresectable tumors, why don't you just resect the entire liver? And that's the whole premise of transplant. You remove not only the tumors that you can see, but also the microstatic tumors that are probably present in the liver, but are invisible on radiologic findings. The challenges of transplant is all these patients, unless you have an identical twin donating to you, need immunosuppression. It is unclear how that immunosuppression affects your disease progression, since the immune system helps keep cancer in check, and it also does limit your options for immunotherapy down the road. It is a higher risk surgery with increased morbidity and mortality up front. And the big question is social equipoise. So there's a limited number of livers, and if we're giving them to people with colorectal liver mets, we're taking them away from other patients. And so we have to make sure that these patients do as well, if not better, than those other patients. And in fact, when it was first tried in the 1980s, it led to terrible outcomes and was a frank contraindication. You could not transplant patients with colorectal liver mets, and appropriately so. But fortunately, Norway is in a unique situation, and they are one of the only countries of which I know where they have more livers than they have patients who need livers. And so they began re-experimenting transplants with colorectal liver mets in the early 21st century. Their first series was published in 2015. 21 patients showed a clear survival benefit compared to chemo alone. When they tightened their eligibility requirements, they reached an 85% 5-year overall survival, which is a critical number because we quote patients around an 80 to 85% 5-year survival for liver transplant in general. So we have to reach that number for colorectal liver mets to reach social equipoise. This is the Kaplan-Meier graph, again, just demonstrating how impressive the overall survival is compared to patients who are getting nothing. The more definitive evidence came out just last year in The Lancet. A transmet study was a multi-institutional randomized controlled trial in Europe looking at liver transplant plus chemo versus chemotherapy alone, about 50 patients in each arm. And you can see from this graph in the intention to treat analysis, the 5-year survival was 56% versus 12%. And in those patients who actually underwent liver transplant, the 5-year survival was 70% versus 10%. These are extraordinary numbers and are super exciting. And this is sort of at the cutting edge of the field and has now become standard of care. Now, the initial thought was that transplanting the patients and removing all their micrometastatic disease would actually provide a cure. That has not been shown to be the case. The recurrence rate is still around 70 to 80% with distant metastases, but despite this recurrence, it is still meaningful survival for these patients. The problem with transplant is finding patients who are eligible based on these strict criteria. So these are 2 studies that came out of Toronto, where I trained, and Rochester, New York, which are 2 of the leading North American centers for colorectal liver metastases transplant. And even those centers that are getting referrals specific to this disease, they're only able to get about 10 to 20% of those patients from evaluation to transplant. And if you look at all patients with colorectal liver metastases, really only between 2 and 4% of patients end up being eligible. Now, I think these numbers are going to increase with time as we loosen the eligibility requirements, but we're not quite there yet. The other challenge with transplant is there's a limited number of organs. And so this top line is the number of people waiting for a liver, and the blue line is the number of livers that are available. Obviously, there's a huge gap there, and so we simply just don't have enough organs to transplant all patients. One great way to overcome this gap is living donor liver transplant. Many of you guys have probably heard of living donor kidney, where you donate a kidney to your wife, your son, etc. You can also do that for a liver. So we take out the right half of your liver regrows in about 6 weeks, and we give that right half to a patient who needs their liver from cancer or for another cause. And this is optimal in cancer cases because we can time your chemotherapy more appropriately, make sure that you have the best benefit from the treatment algorithm. And it has significantly improved outcomes in patients with colorectal liver metastases. The number of transplants for colorectal liver mets has actually been increasing in the last few years, but that increase is largely being driven by sort of lower quality extended criteria donors. And this slide came courtesy of Dr. Hernandez at University of Rochester. And you can see this red line here are the older donors, extended criteria, and their survival is markedly less than the living donors, which are the green line here. As Dr. Mizrahi mentioned, I'm a recent transplant myself in New Orleans. I've been overcome by the generosity and the kindness of people here, and so I think we need to utilize that generosity and kindness and get people to start donating more of their livers to their friends, to their book club members, anyone who might need a liver transplant. Another option, and I'm running out of time, and I apologize, is auxiliary transplant modalities. I'm going to skip these slides, sorry, for the interest of time. So a few conclusions. My best advice to patients is don't get cancer. Please put us all out of business. That's the best possible outcome. Unfortunately, it's not a very realistic one, as we talked about in the beginning of this slide, as the epidemiology shows that colon cancer is only increasing. But there is hope. There is new hope. There's constantly new therapies being introduced. Just 30 years ago, we weren't even doing surgery for colorectal liver mets, and now we're doing transplants. We have immunotherapy through hepatic artery infusion pumps. It's really an exciting time to be in the field, and there's certainly something else that is just around the corner. In case I didn't make this point clearly enough, I think all colorectal liver patients need to see a surgeon. And if you don't like our answer, find another one. We all have different backgrounds, different biases, different training, and ask somebody else. This review process, again, this was picked deliberately, should be multidisciplinary. Lots of people trying to figure out the best thing to do for these patients because there are so many options. In cases like metastatic pancreas or metastatic cholangiocarcinoma, there's just not that much that we can offer for our patients. But here, there's combinations of chemotherapy, surgery, ablation, Y90, transplant, pumps, and there's a ton of things that we have that we can help our patients. Which brings me to my final point, and that we really need individualized treatment plans that navigate the specific disease of the patient, that disease biology, that patient's social circumstances. And so this does take a little bit longer in tumor board to find the exact right solution for that individual patient, but that is time well taken and time that we owe our patients to make sure that they have the best possible outcomes from this disease. Thank you. I think I'm out of time for questions, but I'm happy to stick around afterwards.